is included within the face. There is a demarcation between the scalp and face. Okay. So face is the front aspect of the head and it extends in between the structure. Superiorly, hairline, adoration position of hairline. Inferiorly, chin and base of the mandible. So from here, hairline, that means forehead is also included in the face and forehead also included within the scalp. Okay. So inferiorly there will be chin and the base of the mandible, on each side auricles. Okay, and forehead is common for both face and the scalp. This is asked in your viva, outline of the face. Now layers of the face. Face consists of two layers, skin and superficial fossa, which containing the muscles of facial expressions. Okay, we will discuss this in details. The deep fossa is absent. This point is very important. Deep fossa is absent in face. Also, it is absent in our abdomen. Okay. Very few areas in our body, deep fossa is absent. Okay. Previous one. So the deep fossa is absent in face except over the parotid gland, where it forms the parotid fossa, and over the buccinator, where it forms the buccinator fossa. In this area, deep fossa is present. You have to remember. Next, so skin. What are the peculiarities of the skin of the face? Skin of the face is rich in vascularities, rich in sebaceous glands and sweat glands, laxity, fixity with the underlying cartilages and over the ear, suspension, all these are peculiarities of skin of the face. Now, superficial fossa. It contains these structures: muscles, nerves, and fat. Muscles of facial expression, nerves and vessels, and variable amount of fat. All these are lying in the superficial fossa. Okay. Next. Blushing. Blushing is rich vascularity of the face, makes the face blush and blanch with the expression and exposure to cold. Okay. Wounds. This comes as explained why wounds of the face heals early. Okay. So rich vascularity results in profuse bleeding as well as rapid bleeding and helps in plastic surgery also. Acne or pimples, how it occurs? It occurs on the face in young adults due to clogging of hair follicles resulting in blockage of sebaceous glands. Okay, so this is the mechanism of acne. The edema of the face, laxity of the facial skin facilities the state of edema. Renal edema first appears in the eyelids and the face and later to the other body parts. Okay. Boils, boil or furrow cells is an infection of hair follicle. Boils of nose and ear is painful because of fixity of skin to the underlying cartilages. Okay. These are the common clinical aspects of face. Next. Okay, now muscles of the facial expressions, they are inserted into the skin of the face, and fat is absent in eyelids, whereas it forms a buccal pad of fat over the cheeks. Suctional pad of fat, it is buccal pad of fat, and this is prominent in infants and helps in suckling milk in infants. Okay, next. Now cleavage lines. This dotted line you can see over the face. These are the cleavage lines or lantern lines of the face. Skin. Cleavage line or lantern lines of skin. These are topological lines and that are produced due to parallel orientation of collagen fibers in the dermis and the underlying muscle. Okay. And the orientation of cleavage line in the skin of face is region specific. Natural wrinkle lines they result from repeated folding of skin perpendicular to the long axis of the underlying contracting muscle of facial expression. And wrinkle lines become prominent in elderly due to loss of skin elasticity. And what is the importance of these cleavage lines? To excise the lesions of skin, like different scars or pigmented patches of skin cancer, the incision lines are given according to the cleavage lines. Okay, and if it is given along the cleavage lines, it will be hidden after the surgery. During healing, there is no less cosmetic harm. Okay, next. Now, muscles of facial expressions. What are the peculiarities? The muscles of facial expressions are subcutaneous and they insert into the skin, except the platysma, hence produces various facial expressions. Morphologically, they are remnant of pedicellus carnosus. Embryologically, the facial muscles are derived from the second pharyngeal arch. And innervation, they are supplied by seventh radial nerve, which is nerve of second pharyngeal pouch, and they contain small motor units. Okay. What are the functions used in facial expressions? Sphincters and dilators of facial orifices, such as mouth or palpebral fissures, and also the nasal apertures. Okay. Next. So, facial muscles of facial expression has been grouped in 6 groups. Okay, we will discuss individual group. According to the location, the muscles are grouped as follows. Muscles of the scalp. Only one muscle is included in the scalp, occipital frontalis. It has 4 bellies. Okay, 2 occipital belly and 2 frontal bellies. Superciliary and orbicularis oculi. Okay, these two are lying around the orbits. Next, see these muscles of the scalp. Here is the frontalis muscle. Okay, these are the belly is lying on the posterior part of the scalp. Okay. Now muscles around the orbit. This rounded muscle around the orbit, this is orbicularis oculi, okay, and another is corrugator superciliary. This is lying here. This muscle is the corrugator superciliary. Okay. Next, orbicularis oculi is important. It has 3 parts. You have to know this muscle can be asked in your viva. Orbicularis oculi can come as a short note. Corrugator superciliary is a small pyramidal muscle at the medial end of eyebrow. Origin is from medial end of superciliary arch. Insertion into the skin of middle part of the eyebrow. And vertical wrinkling of the forehead. These actions are important. Name of the muscle and its actions. Okay. Vertical wrinkling of the forehead as an expression of frowning assists the orbicularis oculi. Orbicularis oculi, it is a broad, flat, elliptical muscle surrounds the circumference of the orbit. It has 3 parts: orbital part, palpebral part, and lacrimal part. Orbital part, it lies around the margin of the orbit. Palpebral part lies in the eyelid. Okay, palpebra means eyelid. And lacrimal part lies lateral and behind the lacrimal sac, forms the seat for the lacrimal sac. What are the functions of these 3 parts? Forceful closure of the eyelids margin. And this palpebral part closes the eyelids gently in sleep or in blinking. And lacrimal part dilates the lacrimal sac, facilitates the lacrimal sac. Okay, that helps in drainage of the tear fluid. Next, now we will go to muscles around the nasal opening. Four muscles are there: procerus, compressor navis, dilator navis, and depressor septi. Next, see here. This is the compressor navis. Here is the dilator navis. Okay. Procerus. Next. So procerus is a small pyramidal muscle containing the medial fiber of the frontalis. What is the action? It forms transverse wrinkles over the bridge of the nose. Expression of frowning and concentration. Okay. Frowning. During frowning, there is formation of transverse wrinkles over the bridge of the nose. Next, we go to the nasal compression layers, dilator layers, and depressor septi. Compression layers, this is transverse part of the nasalis, helps in compression of nasal aperture. Dilator layers, it lies over the alar part. It is also known as alar part of the nasalis and helps in dilatation of the nose. And depressor septi, it helps in dilatation of anterior nasal aperture, puts the nose and the nasal septum downward. Okay. So these are the functions of three parts of the nasalis. Next. Now muscles around the lips. So many muscles are present here. All these muscles will be asked. Orbicularis oris, buccinator, levator. These two are important muscles. Orbicularis oris and buccinator can come as a shortcut. Okay. Next is levator labii superioris, alicinase, zygomaticus major, zygomaticus minor, levator labii superioris, levator anguloris, depressor anguloris, depressor labii inferioris, anterior and rhizolius. All these are lying around the lips. Okay. Silence, everyone. Okay, next. And these muscles are named according to their function and according to their location. Okay. So see here. This is depressor septi, part of the nasalis. Here is the levator labii superioris alicinase. Levator labii means it helps in elevation of upper lip and extending up to this angle upper bridge of the nose. Here is the zygomaticus minor, zygomaticus major, lying over this zygomatic bone. And always remember, zygomaticus minor is filial to the zygomaticus major. Now here near the angle of the mouth, here lies the levator labii superioris, levator anguloris. Here is the buccinator. Here is depressor labii inferioris, depressor anguloris, and here is rhizolius. Okay. On the both sides, these muscles are lying, but has been sewn in one side to cut open the other muscles. Okay. So these are the muscles lying around the oral cavity or around the lips. Next. So these are the origin, insertion. You have to know the action mainly. So levator labii superioris alicinase helps in elevation of upper lip and dilates the nose. Levator labii superioris helps in levator means elevation. Okay. Labii means lips. Superioris means upper lip. So elevation and inversion of the upper lip. This will be lip. And zygomaticus major and minor, they use the angle of the smiling. Okay. Smiling. Elevation of the upper lip, exposing the upper teeth and forms the nasolabial groove or furrow. Then levator anguloris, elevation of angle of the mouth in smiling and forms the nasolabial furrow. Then ventral, it of lower lip in drinking and expressing doubt or disdain, and wrinkling of the skin of the chin. Metalis. Then depressor Labile inferioris. It is the quadrilateral muscle. It pulls the lower lip downward and little laterally, and it helps in expression of irony, sorrow, melancholy, and doubt. Okay, and this is also important. You can be asked in your viva which expression is done by which muscle. Okay, that is also important. Next, change. Because it is continuation of posterior fiber angle of the mouth. Depressor pulls the angle of mouth downward and lateral. Then buccinator. It is the muscle of cheek and it is pierced by parietal nerve, buccal branch of mandibular nerve. Outer surface is covered by buccopharyngeal fossa. Buccinator and orbicularis oris. These two are very important. Comes as a short note. Okay. Buccinator has three types of fibers. Upper fiber, the outer surface of alveolar process of maxilla. Middle fibers from perigomandibular raphe. Lower fibers from the alveolar process of mandible opposite the molar teeth. How it inserts? All these fibers converge towards the modulus. Modulus is a point where all the muscles around the lip they are converging, okay, and forming a rounded globular structure, thick rounded structure. Fibers converge towards the modulus near the angle of the mouth, and here the central perigomandibular fibers intersect. That means these middle fibers are intersecting in the modulus, and those from below cross to the upper part of orbicularis oris, and those from above cross to the lower part. And the highest maxillary and lowest mandibular fibers of the buccinator continue forward to enter into corresponding lips without decussation. Okay. What is the function? It flattens the cheek against the gum, prevents accumulation of food in the vestibular mouth. It is the whistling muscle. That whistling muscle is important. Okay. Asked in viva and MCQ. Buccinator, this word in Latin, its meaning is trumpeter. Okay. Helps in whistling. Next is orbicularis oris. It consists of four quadrants: upper, lower, left, and right, and each consists of large parts peripheраlis and small parts marginalis. Pars marginalis is well developed in humans. Now these two parts, pars peripheраlis, lateral stem is attached to modulus, consists of extending fibers and from muscles converging at the modulus. Pars marginalis, single band of muscle fibers, and that originates from modulus. What is the insertion? These fibers diverge and form a triangular muscular sheath in each lip, cross the midline, and interlace with opposite side fibers. In the midline, these fibers interlace with opposite side fibers, insert at the side of vermilion zone of lips. This is insertion for pars peripheраlis. This is insertion for pars marginalis. Vermilion zone means the pink area is included within the vermilion zone. Okay. So, what is the action? Pars peripheраlis helps in closes the lips, compresses lips against teeth, and helps in mastication. And this pars marginalis is associated with speech and production of musical tones. Okay, final accents. So you prepare this for as a short note: buccinator, orbicularis oris, also orbicularis oculi for eye muscle. Okay, another muscle you have to know the name and the action. Next. Next, muscles around the auricle, around the ear. Three muscles are mainly present: auricularis anterior, auricularis posterior, auricularis superior. This seat of muscle, platysma. Okay. Next, see this seat of muscle lying in front of neck. This is platysma, and near the ear there is auricularis muscle. I will show you another picture. Next, seat of muscle in the neck. How it originates? This is asked in Viva very frequently. Platysma. I'll also can be given your OSPI question, platysma. Okay. Origin, upper part of fossa covering the pectoralis major and deltoid muscle. This is the origin. Upper part of the fossa covering pectoralis major and deltoid muscle. Insertion, fibers run upward and medially. Anterior fibers is inserted over base of the mandible. Posterior fibers, skin of lower face and lip. This is continuous with rhizolius. Action, what is related to whistling, accumulation of food in the vestibule of mouth. Okay, you remember this picture, you will be able to tell the signs. Next, nerve supply of the face, it has sensory supply and motor supply. Motor supply is by this facial nerve, branches of facial nerve. The muscles of facial expression, these are supplied by the facial nerve as they are derived from second pharyngeal arch. Different arches, different nerve. Nerve of second arch is facial nerve, so it will be supplied by facial nerve. Facial nerve supplies this muscle through its 5 terminal branches: temporal, zygomatic, buccal, marginal mandibular, and cervical. Next, muscle. Muscles of facial expression supplied by the branches of facial nerve are temporal branch. These are the 5 branch, 1 to 5. Temporal branch will supply frontalis, auricularis muscle, orbicularis ocular, and corrugator superciliary. Zygomatic branch, it will supply lower half of orbicularis oculi. Buccal branches supply muscles of cheek and upper lip. Marginal mandibular muscles of lower lip. Cervical branch supply the platysma. Okay. Next, see these are the 5 branches. Facial nerve, it is divided into 5 branches. Here is the temporal branch. This is zygomatic branch. This is buccal. Here is the marginal mandibular along the margin of mandible, and going to the neck is cervical branch. See here, cervical branch is supplying the platysma. Okay. Next, this is the clinical testing of muscles of facial nerve. Can be performed with these 5 levels. Frontalis asks the patient to look for upward without moving his head upward. Observe for the transverse wrinkling of forehead. Corrugator superciliary asks patient to frown. Observe the vertical wrinkling between these 2 eyebrows. Orbicularis oculi asks the patient to close the eyes tightly. Orbicularis oris asks the patient to close the mouth tightly, and buccinator asks the patient to blow out air forcefully, that is whistling, asks the patient for whistling. Next is sensory supply of the face. That is also asked. Skin of the face is supplied by branches of trigeminal nerve, except the skin over the angle of the mandible, which is supplied by great auricular nerve. And distribution of trigeminal nerve according to the development of the face. Upper quadrant of the face is developed from frontal and posterior, supplied by ophthalmic division of the trigeminal nerve. Trigeminal is 5th cranial nerve, that's why it has been V1, V2, and V3 like this. 5, okay? So, and this is area supplied by the maxillary division of trigeminal nerve, middle 1/3 developing from maxillary process, lower part of face developing from mandibular process, the pink colored one supplied by mandibular division of the trigeminal nerve, and this part near the angle of the mandible near the ear and posterior part of the temple. This part is supplied by great auricular nerve branches from the cervical plexus. Okay. Next, so these are the nerves supplying the face. The following branches of trigeminal nerve and cervical plexus that is supplying the face. Ophthalmic division is between these branches. Supratrochlear nerve, supraorbital nerve, lacrimal, infraorbital, external nasal. From the maxillary division, three branches. Division, auriculotemporal nerve, buccal nerve, metal nerve, and branches from the cervical plexus. There is anterior division of great auricular nerve, transverse anterior lesser occipital nerve, and supraclavicular nerve. All these nerves are supplying the sensory supply to the face. Okay. See the course. This is common carotid divided into internal and external carotid. From the external carotid, facial artery is arising, entering the face near the angle of the anterior angle of masseter. Masseter is lying here. Entering the face, the course is tortuous, giving upper lower buccal lateral nasal branches. Okay, and continues above near the medial angle of the eye and the angular artery. So this is the course of facial artery. Next, this is facial artery course. Schematic diagram in practice. Superior labial, inferior labial, and this is the angular artery. Okay, lateral nasal, all of the branches of facial artery. Next. So this is beginning, termination, course and branches. Next, tortuosity of face prevents undue pull of its wall during the movement of the mandible. Okay. Another artery is present. Transverse facial artery is a branch of superficial temporal artery that is the anterior border of the hand to enter the face, transforward between masseter and tegmental arch to supply the face, and it is accompanied by buccal branch of facial nerve, transverse facial artery. Next, we go to the vein. Two veins are present. Face is drained by facial vein and retromandibular vein. Next, it is the main vein of the face. How it is formed? It meets as angular vein by the action of supraorbital and supraorbital vein. Branch straight downward and backward to the anterior inferior angle of the mouth, pierces the interesting layer of deep cervical fossa. Joins with the anterior division of retromandibular vein below the angle of the mouth to form common facial vein, which drains into internal jugular vein. What are the tributaries corresponding to branches of facial artery? Retromandibular vein, it is formed by union of superficial temporal vein and the maxillary vein in the parotid glands, and it exits the parotid gland, divides into anterior and posterior division, and anterior division joins with the facial vein to form the common facial vein. Next, see the course. This is the facial vein arising from medial angle of the eye, going downward, joins with the anterior division of retromandibular vein, forming common facial vein. Common facial vein is draining into internal jugular vein. Next, important, this is one clinical aspect, comes as a short note. Dangerous area of face, very important. It is devoid of valves and facial vein communication with the cavernous sinus through these two channels, angular vein and supraorbital vein, that communicate with the superior ophthalmic vein, which is tributary of cavernous sinus. Another is deep facial vein that communicates with pterygoid venous plexus, which has communication with cavernous sinus via emissary vein. These connections are important. And facial vein rests on the facial muscles, which facilitates the spread of infection and emboli from facial vein to the cavernous sinus. That's why if an infection or emboli formation occurs in this area, it may be drained up to the cavernous sinus. Okay, that's why this area is known as dangerous area of the face. Understood? So lower part of nose, upper lip, okay, and adjacent parts of the cheek. This part is known as dangerous area of the face. Next, okay, lymphatic groups, upper area, middle area, lower area. Upper area is draining into preauricular or superficial parotid. Middle area into submandibular, lower area into submental group of lymph nodes. This is lymphatic drainage of face. Next, okay, posterior most part of the scalp drains into occipital node and they lie superficial to trapezius near the origin or at the apex of posterior triangle of the neck. Okay, so these are the lymphatic drainage. Superficial parotid node is lying just anterior to the tragus. Posterior auricular nodes drain the skin of the posterior part of temporal fossa, mastoid process, parietal region of scalp, posterior part of auricle, posterior part of external acoustic meter. So this is lymphatic drainage. Next, this is development. See the processes. Frontonasal process. These are maxillary process and this is mandibular process. This will be discussed in your embryology. All these processes are joining to form this face. And an important clinical aspect is cleft lip. Okay. If there is failure of what is cleft lip, it is a congenital split in the upper lip of one or both the sides of its center. Usually, the upper lip of hair has a clip. Hence, this cleft lip is commonly called hair lip. Formed due to failure of fusion of maxillary process with the medial nasal process, part of frontonasal process, results in cleft lip. It is treated generally, surgical correction is done. Okay. Next. Okay, that's all. Any queries regarding face? So you have to know the muscles of facial expression, facial artery, facial vein. Okay. All these are important short notes.
Equilibrates on both the sides. There is 5% helium left in this spirometer, which means there should be 1 liter of air in the amount of the air that is released into this spirometer. Okay, so this is how residual volume is checked. Okay, now see, there are two very important diseases, obstructive and restrictive lung disease. In clinical practices, whenever you will be dealing with any grade of patient, these are the two diseases that you will be dealing with all your life in the patient. So you must have a very clear concept about what is obstructive lung disease and what is restrictive lung disease. Okay, now normal lung. In the normal lung, there are normal airways. Okay, the airways are surrounded by lung parenchyma, which consists of lung parenchyma ki thake? Air space, हाँ बोल, alveoli and air spaces. Now normal lung ki hocche? Airways are there, lung parenchyma is there. In lung parenchyma, airways are embedded and the lung parenchyma comprises of the air spaces and alveolar system. These lung parenchyma is elastic in nature. Normal physiology, when you inspire, what happens? What is happening during inspiration? When you are inhaling the air inside your system, what is happening? The chest wall is expanding. Chest is drawing the lungs outward. So, the airways, they are normal physiological condition. The airways, they remain open by the elastic traction of the lung parenchyma, which are present around the airways. So when you inspire, normally your lungs are expanding. So the airways, they will become wider than normal. Pressure inside will go down, air will come in. Now, what are the muscles involved in inspiration? Main muscle, diaphragm. So when diaphragm contracts, your lungs expand, the chest wall pulls the lungs outward, air goes in, and then what happens during expiration? So, does any muscles are involved during expiration? Exactly, it is a passive process. You are inspirating, muscles are contracting, and at the end of inspiration, the diaphragm relax, the muscles relax, and the lungs get back to its normal position. And while it is the inward pull, when the lungs are pulling, drawing the chest wall inward, normally what is happening? The airways, while inspiration they were drawn outward, they become wider than normal. During expiration, the lungs is pulling the chest wall inward and the airways they are becoming narrow and the air is going out. This is normal physiology. So during expiration, in normal physiological limits, airways they do get narrow. This is normal condition. But in restrictive lung diseases, can you say what is happening in restrictive lung disease? Whatever happen, you must have very clear concept about obstructive lung diseases and restrictive lung diseases. What is happening in restrictive lung disease? Can anybody say? Don't say that fibrosis is restrictive lung disease, consolidation is restrictive. কি হচ্ছে দেখুন কোন পার্টটা এফেক্টেড হবে কি হচ্ছে এয়ারওয়েজে কি হচ্ছে decreasing sorry that normal lung, okay, there are airways and there is lung parenchyma surrounding the airways. You must remember, in restrictive lung disease nothing happens to the airways. There are no obstructive element present in the airways. The lung parenchyma increases in substance. Why? This may be because of the inflammatory changes. This may be because of the widespread interstitial inflammation. This may be because of fibrotic changes. Fibrosis means there is excessive deposition of collagenous material. There is excessive deposition of biological material. Anything that is getting deposited, either there is inflammation or there are fibrotic changes or there are infiltrative changes. Any changes that is increasing the lung parenchyma overall, that is causing the increase in the substance of the lung parenchyma, causes restrictive lung diseases. Am I clear? So when in an elastic tissue, in an elastic lung, when a lot of fibrotic materials are deposited, will it become less stiff or will it become more stiff? More stiff. So if it has become more stiff in nature, if it has become more elastic in nature, when you inspire, there is no problem. Okay, velocity of the air entry into your lungs depends upon two factors. First is airway caliber. Caliber of your airways, how well functioning your airways are. And second is with how much speed your lungs are able to expand. These are the two factors on which the velocity of air entry into the lungs depend. In restrictive lung disease, there is no problem with the air entry. Air entry you can take with a lot of velocity, you can take the air inside your lungs because the airways are normal. But because the lung has become more elastic in nature, when you inspire, when you expand, with little stretch, what will happen? A very tight thing, very elastic in nature, with little expansion, it will recoil back. Normal lung, what is happening? Listen carefully. Normal lung, the inward pressure with which the lungs pulls the chest wall inward, and the pressure with which the chest wall pulls the lung outward, that are equal and opposite. And we say functional residual capacity is achieved at equilibrium. Okay, but in restrictive lung disease, restrictive lung diseases, what is happening? The lungs are, what is happening? Restrictive lung diseases, there is problem during inspiration or problem during expiration? There is problem during inspiration. Expiration, you are just exhaling the lungs. This is the function of the airways. During inspiration, when you are inhaling the lung, the air can go in, but the lung cannot expand. The chest wall is unable to pull the lung to the normal size, pull the lung outward to the normal size, because the lung parenchyma has increased the substance and it has become extremely elastic in nature. So with little pull, it goes back. And if it is not able to contain or inhale the maximum amount of air that it is supposed to, so inspiratory, what is happening? The lungs are functioning at smaller volume or larger volume? Smaller volume. Lungs become smaller. First reason, it is becoming very much elastic. The inward pull, the inward recoil of the lung has increased. Because of the increase in the lung substance, the inward recoil of the lung has increased a lot. So the lungs are drawing in and the lungs are operating at smaller volumes. Okay, and because it has become very much elastic in nature, with little expansion, it will recoil back. So the amount of air that is supposed to go in will be less than the normal. This is what is happening in restrictive lung diseases. Okay, so here the lungs are operating at smaller volumes. So what will happen to the total lung capacity? It will decrease. In restrictive lung diseases, all the parameters will go down. Total lung capacity will decrease, residual volume will decrease, vital capacity will decrease. Okay. Now, are you clear with restrictive lung diseases? So, lung fibrosis, lung consolidation, any space occupying lesion, any widespread interstitial inflammation, these are all, they fall under the category of restrictive lung diseases. Now, what are obstructive lung diseases? Can you tell anybody what is restrictive lung diseases? Remember, first the problem is during inspiration. When you are taking the air in, because the lung substance, the lung parenchyma has increased in substance, it is not able to expand. With little expansion, it is going back. Okay, so the main problem is during inspiration. Now, what happens? What happens? Can you tell? What happens in obstructive lung diseases? Anuna? Very good. What are the conditions in which there are obstruction in your airways? কি হচ্ছে bronchitis, chronic bronchitis? Yeah, কেন? What happens in chronic bronchitis? Exactly. Excessive mucus secretion, unduly mucus secretion. What will happen? Excessive mucus secretion, it occurs in chronic smokers. When somebody is smoking chronically for suppose 10-12 years, the smoke particle irritates the airways and they start causing excessive secretion in unduly amounts. And in that process, there occurs hyperplasia of the secretory gland and the metaplasia of the goblet cells, which are mucus secreting cells. So, when excessive secretions occur, ultimately they get deposited in your airways and they block the passage of the airway. They block the airways. They cause the airways to become more narrow. Another very important disease of the obstructive lung diseases. What happens in emphysema? Right. Now listen carefully what happens in emphysema. In emphysema, smoke particles, they disturb the alveoli. When the alveoli are disturbed, what they cause? They cause there is chronic stimulation or overstimulation of alveolar macrophages and neutrophils. Now when alveolar macrophages and neutrophils, they are eating or phagocytosing these carbon particles continuously for many years, what is happening? Very rapidly, will you spill out? Sometimes you spill out some of the food particles. When the alveolar macrophages and neutrophils, they are chronically phagocytosing continuously for continuous periods of time, they regurgitate proteolytic enzymes, proteolytic proteases, and some of these proteases are elastases. What these elastases do? They elastases কি করবে? হ্যাঁ বল, বুঝিস তো? হ্যাঁ, elastic টিস্যুটাকে নষ্ট করে দেবে। lung parenchyma elasticity will be destroyed gradually over the time. And now listen, if the elasticity of the lung parenchyma is destroyed, lungs will become more stiff or less stiff? Less stiff, and it will become more compliant to pressure changes. So there will be initially, in the beginning of the disease, there will be no problem with the inspiration. You will be able to inspire in fact a lot of air, because with little pressure the lungs will overexpand. With little pressure changes, with little stretch, it will overstretch. So a lot of air will go inside your lungs. Okay. Now, okay, what is, so alveolar macrophages, some of them are the elastases which are destroying the elastic tissue. So when the elastic tissue is destroyed, what will happen to the size of the lung? It will become smaller or larger? Larger, because the inward recoil of the lung is lost. So the lungs become quite baggy in shape. They become, in COPD X-rays, when you see, you'll see very large lungs. The lungs become very large. So one reason is that the elastic nature, the lung parenchyma is lost, which is responsible for causing the inward pull of the lungs. So that nature of the lungs is lost. Because of that, one thing, your lungs becomes baggy in nature. Now tell me, if I have obstructive lung diseases, will I be having problem during inspiration or expiration, and why? Expiration, why? তো inspiration কেন হচ্ছে না? হ্যাঁ, so when inspiration, when the lungs, there is no problem with the expansion of the lungs. The lungs are expanding and even the airway is becoming wider than normal. Okay, so initially a lot of air comes in, but then during expiration, because they become very narrow and some of the small airways, because the traction pull that is keeping them open, that is lost, some of the smaller airways they completely shut down. So air trapping occurs in obstructive lung diseases. And when air trapping occurs in obstructive lung diseases, what is happening? What will happen to the residual volume? Residual volume will increase. And what will happen? What is the hallmark of these obstructive diseases? How their lungs look like? How their chest looks like? Barrel shaped. Barrel shaped. Barrel shaped. Okay. So why it occurs? Because every time you inspire, you are not able to expire the total amount of air. So some amount of air is getting captured in the lungs every time the person is doing expiration. Now listen, initially there will be no problem in inspiration, but if somebody is like, automatically the person will distress. After a certain point, will that person be able to inspire normally? No. So what will happen to the vital capacity? Eventually the vital capacity will decrease. So a situation in which total lung capacity increases, vital capacity decreases, and residual volume increases. What is this? Obstructive lung disease. And total lung capacity decreases, residual volume decreases, and vital capacity decreases. What is this? Restrictive lung diseases. So another condition is there. I'll tell you, first listen the features and then answer. Okay. There is hyperreactivity of the smooth muscles. There are eosinophilic activity is increased. Okay. Inflammatory condition is present and the disease is episodic in nature. Bronchial asthma. Bronchial asthma. It is also categorized under obstructive diseases because obviously inflammatory mediators are there, the airways become inflamed, but bronchial asthma, there are also acute episodes of bronchial asthma that takes place, so we also include it under acute. Okay. So in the spirometric changes, in the restrictive lung diseases, the entire parameters will go down. All of the parameters will go down because the lungs are operating at smaller volume. The lungs are operating at smaller volumes, and the lungs is less stiff or more stiff? More stiff and less compliant. But in obstructive lung disease, the lungs will be operating in higher volumes and they are less stiff and more compliant to pressure changes. Okay. Now let's come to the expiratory flow rates. Now the maximum amount of air that you can inhale is called forced vital capacity and all those things. What is vital capacity? Tell anybody. What? Vital capacity. You must learn it by what is the actual. Don't learn it by the values that TV plus this. You forget. Maximum amount of air that you can inhale and the maximum amount of air that you can exhale. That is vital capacity. So what can be forced vital capacity? When you are exhaling the air or throwing the air out in this spirometry tube, what is forced vital capacity? You are exhaling it with maximum effort, as hard, as fast, as rapidly you can. That is called forced vital capacity. Now suppose the total lung capacity of a person is 6 liters. What can be the vital capacity of this person? Total lung capacity is 6 liters. In a normal person within physiological range, if the total lung capacity is 6 liters, what will be the forced vital capacity? Or the vital capacity? 5 liters. 1 liter you cannot get out of your lungs because that is the residual volume. So 5 liters. Now when you are exhaling the air out in this spirometer very rapidly, initially if you are exhaling out it very rapidly, initially the velocity and the amount of air that has come out of your lungs will be more, and gradually, because the air concentration has reduced in amount, literally it will be less, the volume will go less. So in normal condition, 80% of the air comes out of your lungs in the first second, and this is known as force expiratory volume, FEV, which is 1, force expiratory volume in 1 second. Okay, the remaining 1 liter will come out in the next 2-3 seconds. So if total lung capacity is 6 liter, you can say total lung capacity is 6 liter, forced vital capacity is 5 liter, and FEV1 is 4 liter. So what is this FEV1 by FVC ratio coming out to be? FEV1 4 by 5 কত হচ্ছে 0.8, 80%. When this value, when this ratio goes beyond 70%, not significant obstruction is present. When FEV1 by FVC ratio goes below 70%, we say that some obstructive condition is present in the lungs of that person. Okay. Now, in restrictive lung diseases, suppose you look very blank. Yes, you. You're listening to what I'm saying. Now listen. If in restrictive lung diseases, the total lung capacity from 6 liter has gone to 5 liter, okay, the forced vital capacity will be, suppose it's 4 liter. FEV1 is 3 liter. 3 by 4, how much it is occurring? 75%. So now listen, restrictive lung disease, the total lung capacity has increased. Total lung capacity from 6 liter, it has become to 5 liter. Okay, now you are from 6 liter, it has become to 5 liter. Forced vital capacity has become 4 liter, and FEV1 is 3 liter. 3 by 4, 75. It is still normal. Why? It is not 70% or below 70%. It is 75%. See? Total lung capacity টা কমে গেছিল, বাট রেশিওটা তো এক থাকছে, রেশিওটা তো 70% এর বেশি থাকছে, তো এটার মানে কি বল দেবাশ্রিতা? When the ratio is more than 70%, even in restrictive lung disease, what does it indicate? Restrictive lung disease কেন? Restrictive lung ভলিউমটা টোটাল কমে গেছে, বাট কোনো চেঞ্জ হয়নি, বিকজ there are no obstruction present in the airways. Because there are no obstruction present in the airways. So what I am trying to say that even in restrictive lung disease, total lung capacity has reduced, residual volume has reduced, forced vital capacity has reduced, but the FEV1 by FVC ratio, there is no significant change. Even the expiration will be better, because the inward pull of the lung is so much that during expiration, when the lungs will recoil inside the airways, it will put extra pressure on the airways, but they are not collapsing, and the air will rapidly will go outside of the lungs. Okay. So in restrictive lung diseases, FEV1 by FVC ratio is not significantly changed. This is what I am trying to explain. Now in obstructive lung diseases, what will happen? The total lung capacity will increase. Suppose the residual volume has become 3 liter. Residual volume has become 3 liter. Total lung capacity is 7 liter. 3 liter is the residual volume. So forced vital capacity will be 4 liter. And suppose FEV1 is 2 liter. So FEV1 by FVC ratio is 0.5-50%. So there is significant obstruction present here. The obstruction is present in the airways. This is the purpose of these expiratory flow rates. Okay. So normal, now one thing. In normal lung, when somebody gives you a total lung capacity 6 liter, forced vital capacity 5 liter, then FEV1 4 by 5, and then restrictive lung disease, total lung capacity is reduced, and you are doing 3 by 4. You might think that if comparison is given between a normal lung and restrictive lung without saying, by seeing the values, you might feel that some obstruction is present. But you always have to compare the amount of air that is gone out in first second with the total amount of air that has that's been thrown out of your lungs. Okay. Okay. Now obstructive lung disease, it will be 50%. Now flow volume loop. Do you people know anything about what is peak expiratory flow rate? Peak expiratory flow rate. Anybody? Peak expiratory flow rate. কতটা, হ্যাঁ, স্পিড এগেইনস্ট ভলিউম, ঠিক আছে, কতটা স্পিডে তুই এয়ারটাকে ইউ আর থ্রোয়িং ইট আউটসাইড অফ ইয়ার লাংস, দ্যাট ইজ পিক এক্সপাইরেটরি ফ্লো রেট। ওকে, নাও ক্যান এনিবডি এক্সপ্লেন দিস? Some extra things I have done here, but this is on a slow volume loop. Okay, what is this slow volume loop? Loop ta ki eta, what is this loop, slow volume loop? When, can everybody see this? যেটা আঁকা আছে নরমাল যেটা, when you are, আচ্ছা ওপরে, just see what I have written. If this is expiration and this is inspiration, after you have done the maximum total lung capacity 6 liter, after you have done the maximum inhalation, after you have done the maximum inhalation, when you are exhaling out, there will be a point when you are reaching the peak expiration flow rate, when you are, so this is the loop that is showing that how you are exhaling out the air from your lungs. Upore ache expiration, first you have inhaled it initially at 1 liter, no air will go in because that's the residual volume, and dhire dhire, little slowly your lungs are going down, means your lungs are expanding, your lungs are gradually expanding as you are taking the air more inside of your lung, and at 6 liter, when maximum inspiration, can you see, at 6 liter, when the maximum inspiration is done, your lungs cannot expand anymore. Ekhanta lekhata dekhi amarta dekam je likhechi, here you are starting the inhalation. Okay, at 1 liter, no air will go in because that's the residual volume. Gradually the curve is going down because your lungs are expanding, and here when total lung capacity has been reached, your lungs cannot expand anymore. Okay, so inspiration will stop there, and gradually in a normal lung, when you have exhaled the maximum air, then you are throwing out the air, peak velocity will reach, and gradually the slope comes down, and after 1 liter it cannot go more because all the air has been gone out, residual volume is there. Now if there is any kind of obstruction in your extrapulmonary airways, if there are any kind of tracheal obstruction, what will happen to this loop? Will it become this normal? It will not become, because when you are inspiring there is certain obstruction present, so you are not able to inhale it with maximum effort, and gradually this loop will be less. The downward, whenever there is any problem during inspiration, the downward curve will decrease. That also, the downward intensity will decrease because your lungs are having difficulty in expanding. And of course, when you are exhaling it, the upward slope will decrease. হ্যাঁ, দুটোই এটা ট্রেকিয়াল অবস্ট্রাকশনে হবে। তোর নিঃশ্বাস নিতেও তোর এক্সট্রা পালমোনারি লার্জ এয়ারওয়েতে যখন তোর প্রবলেম আছে, তোর নিঃশ্বাসটা নিতেও তোর প্রবলেম হচ্ছে, ঠিক আছে, আর নিঃশ্বাসটা ছাড়তেও তোর প্রবলেম হচ্ছে। Now what will happen in restrictive lung disease? Inspiration will not start from 1 liter, it will be from the negative side of the slope, half liter থেকে ধর শুরু হচ্ছে, নিচের স্লোপটা কি হবে, নিচে কতটা নিচে নামবে, অনেক কম নামবে, রেস্ট না হাফ লিটার থেকে তো শুরু হচ্ছে, downward slope, the intensity of the downward slope will be very less because downward slope is indicating, কি বললাম, velocity of air entry depends upon two factors, the rate at which your airway calipers and the speed at which your airways are expanding. Now restrictive breath কি হচ্ছে, expansion কমে যাচ্ছে, তাই জন্য কি হচ্ছে, downward slopeটা কম হবে। Downward slope indicates the rate and the speed at which your lungs are expanding and accumulating more air inside your lungs. So that expansion is gradually getting reduced in restrictive lung disease. So the downward slope will be less. The downward slope will be decreased. And will this slope continue till 6 liter? It will end nearly at 3 liter because total lung capacity is achieved at smaller volume because the lungs are functioning at smaller rate. The lungs are operating at smaller volume. Now, peak expiratory flow rate কি হবে? Peak expiratory flow rate এতটা আসবে নাকি অনেক নিচে অবধি আসবে? নিচে অবধি আসবে। কেন নিচে অবধি আসবে? Again, because the lungs are operating at smaller volume, so you cannot throw the air out with that high velocity as it is capable, as a normal person with normal functioning lung is capable of doing. ठीक है? So peak expiratory flow rate will also be reduced in size. Now, what will happen in obstructive lung disease? Oh, should I try one? Normally কি হচ্ছে, this is occurring in normal lung. ঠিক আছে? তুই maximum exhale করছিস, it is coming back to the normal because the lungs are expanding, so there is maximum expansion of the lungs at the time of inspiration. Now if there is any kind of obstruction in your extrapulmonary airways, tracheal obstruction আছে, এই জিনিসটা কি হবে? ধর মন থেকে কিন্তু স্টার্ট হচ্ছে, রেসিডিউল ভলিউমে কিন্তু কোনো প্রবলেম নেই, মন থেকে স্টার্ট হচ্ছে, কিন্তু তোর এক্সপ্যানশন ক্যাপাসিটি অফ দি লাংসটা কিন্তু কমে যাচ্ছে। ঠিক আছে? দিয়ে তোর 6 অবধি যাচ্ছে। আর এইখানে কি হচ্ছে, যখন তুই এক্সহেল করছিস, এয়ারওয়েজের বিকম এয়ারওয়েজ small, exactly. So when you are exhaling, the velocity and the power and the capability of the exhalation is also decreased. তাই জন্য কি হচ্ছে? This is occurring in tracheal obstruction. ঠিক আছে? Now এবার restrictive হবে। restrictive কি হবে বল? It will start from, চল এখানে half liter আছে, it will start from half liter and 3 লিটার আসবে। কেন 3 লিটার আসবে? কেন 3 লিটার আসবে velocity? কেন 3 লিটারে expand হচ্ছে না? With there is no problem in the entry of the air. Residual volume, the lungs are operating at smaller volume, so obviously the total lung capacity has reduced. Everything, the entire parameter in whole has gotten down. ঠিক আছে? তাই জন্য residual volume is less. Suppose it's 500 ml. So when you are inspiring, the ability of your lungs to expand has become very much diminished, has become very much reduced, and the total lung capacity is achieved at very smaller volume as compared to the normal lungs. But then what will happen to this graph during expiration? What are the condition of airways in restrictive lung disease? ওটা তো ছেড়ে দে, ওটা সরি restrictive lung disease. Restrictive lung disease ইলাস্টিসিটি কিছু হচ্ছে না। Restrictive lung disease, the lungs has become more tight, more stiff. The inward pull of the lung is more. That is why there is problem in expansion. Chest wall problem হচ্ছে, chest wall একটু দেই, it is going in. With little stretch, it is the inward pull of the lungs is becoming more. Restrictive কি হচ্ছে? Now listen. There is no obstructive element present. There is, you are understanding, you people, whatever I am saying, or is Urdu and Hebrew to you people? বুঝতে পারছিস? There is no obstructive element present in the airway. So what is happening? Anybody sitting back? See, this is very important. You must have a clear idea about obstructive and restrictive lung diseases. You have been dealing with these two diseases all your life in the clinical practices. There is no obstructive element present in the airways. So while you are exhaling the air out, there is no problem. So this will be like this. But the expiratory flow rate, velocity with which you are exhaling the lung, exhaling out the air from your lung, that velocity and the rate will be reduced, because restrictive lung, we cannot throw the air out with as high velocity as the normal lungs are doing, because the volume has become very less. So automatically the maximum force you apply, will it reach here? It will never reach here. বুঝতে পেরেছিস? Restrictive lung disease কি হচ্ছে, ভলিউম তো বেড়ে যাচ্ছে, লাং প্যারেন্ট কাম, ভেলোসিটিতে কোনো প্রবলেম ইনিশিয়ালি কি হচ্ছে, ইন্সপাইরেশনে কি কোনো প্রবলেম হবে? ইনিশিয়ালি অবস্ট্রাকটিভ লাং ডিজিজে কেন প্রবলেম হবে না? এক্সপ্যান্ড হচ্ছে ওয়াইডার দ্যান নরমাল, এয়ার এন্ট্রি হচ্ছে, বাট বিকজ গ্র্যাজুয়ালি air entry is occurring and then air exhalation, all the air is not coming out, little bit trapped. So initially distress, the patient will automatically go in distress, and after a particular point of time even inspiration will cause problem. After a particular point of time even inspiration will cause problem, but initially there will be no problem in the graph, in the volume group, in the flow volume group. There will be no problem in the initially in the inspiration in obstructive lung disease. Now what will happen during expiration? এয়ারটাই কি হবে, লাংসটা তো কোলাপস করছে, ঠিক বলেছে, লাংসে কোলাপস করছে কারণ ইনওয়ার্ড পুলটা লস হয়ে যাচ্ছে, স্মল এয়ারওয়েজ গুলো they are becoming more narrow because the radial traction, elastic traction on the airways is lost, so they are becoming more narrow than normal, and the small airways they are getting closed, they shut down completely, and if more pressure, so ultimately if you apply more pressure it will cause more problem, ঠিক আছে? So what will happen to the graph now? Like this, and then when you reach a certain point where you will be exhaling, where you will be putting the maximum pressure to exhale it with the maximum velocity, there will be sudden drop, in the expiration, and then very slow expiration with very less volume will occur. Very slow expiration with very less velocity will occur. Prolonged expiration will occur. Is this look clear? Any questions? Is this look clear? Yes. So can anybody now tell me, give a brief summary what obstructive and what restrictive diseases are? Anybody? What will happen in restrictive disease? What will, a lot of you people have understood. Can anybody tell what will happen in restrictive lung disease and what will happen? Brief. I am not saying give a lecture, give an entire class on this. You people sitting in the back, can you tell what is happening in restrictive lung disease? In restrictive lung disease, just tell me problem will be during inspiration or problem will be during expiration? Problem will be in inspiration or problem will be during expiration in restrictive lung disease? Inspiration. Why? Because I am repeating it again, in restrictive lung diseases the lung parenchyma has increased in substance, so it is becoming more rigid, it is becoming more stiffened, and it is becoming less compliant with pressure changes. More stiffened and less compliant with pressure changes. So with little stretch, it is not going to get more stretch to the normal lung, it is going to recoil back. And while it is going to recoil back, the pressure and the force with which it is constricting the airways, the pressure will be so much that initially the air will come out with rapid velocity. This is what is happening in restrictive lung diseases. Am I clear? Now what is happening in obstructive lung diseases? Elasticity is lost, so there is decreased resistance initially to the air entry, but there is increased resistance to air outflow. At the time of expiration, the restriction and the resistance to the airways is more, and ultimately the air will keep getting trapped, and ultimately the patient will reach a point where both the inspiration and expiration both will be problematic. Clear? So, okay. Now these are the obstructive and the restrictive lung diseases. Any other, can you name some other diseases that will cause problem in your inspiration and expiration and will reduce? Acha, can you tell me any condition, pathological condition in which the vital capacity of the lungs increase? Are there any pathological condition in which the vital capacity of the lung increases? There are no pathological condition of the lungs in which the vital capacity increases. Vital capacity decreases in every situation, in every pathological condition. This is the first thing that you must remember. In all pathological condition, vital capacity will reduce. Okay. Now, any other, if there are any skeletal, there are four, your inspiration and expiration and vital capacity obstruction, they operate at 4 levels. First of all, you have to remember your highest center, central nervous system. Which nerve supplies the diaphragm? Phrenic nerve. Root value? Cervical. C3, C4, C5. So, if in poliomyelitis, if there is no firing, if the neurons are not firing, if the phrenic nerve is not, if your diaphragm is not contracting, inspiration and expiration will not occur. So, this is at the level of the neuronal circuit. At the level of the muscular, any myopathies, what will happen in myositis? What is myositis, do you know? It is an autoimmune condition where the antibodies are produced against your muscles. If the muscles, if antibodies produced are attacking your own muscles, and ultimately when it attacks your respiratory muscle, will you be able to contract the muscle and do inspiration, expiration? No. Then another, Yes. Now, this is not myasthenia gravis. Myasthenia gravis is different. This is myositis. Okay. And skeletal deformity. Can you name any skeletal deformity? If your chest wall is only deformed, scoliosis, kyphosis, okay. Of course, there will be difficulty in breathing. Okay, so nervous system problem, muscular system problem, skeletal deformity, and pleural effusion or a lung problem hoye gelo. Pleural effusion, if there is fluid accumulated in the in your pleural cavity, if there is any kind of stab injury, if there is air entry in the pleural spaces, then again the equilibrium at which FRC will be disturbed. So all these things will occur.
Okay, kidney in Latin, renal, what is synonymous to the kidney, and nephros, it means kidney in Greek. Okay, so kidneys are, so these are the two kidneys. Kidneys are two bean-shaped reddish brown organs within the abdomen, situated on the posterior abdominal wall, and they are the major excretory organs. Remove the waste products of protein metabolism for our survival. Okay, so these are the now where is the location of kidney? The kidneys lie on the posterior abdominal wall. See, these are the location. These lines divide the abdomen in 9 quadrants. Okay, so one on each side of the vertebral column. Behind the peritoneum, the kidneys are lying. Opposite to thoracic and upper 3 lumbar vertebra, T2 and 2 L3 vertebra. This is the vertebral level, and they occupy the epigastric, you can see here, or epigastric, hypochondrial, lumbar and umbilical region, both the kidneys. Okay. The right kidney lies at a slightly lower level than the left one due to the presence of liver on the right side. Okay. So right one is slightly lower. You have to remember. Hey, silence everyone. Their long axis are slightly oblique, that is being directed downward and laterally. That means upper pole is nearer to the vertebral column and lower pole is away from the vertebral column. So you can see upper pole is almost 2.5 centimeter away from vertebral column. Near the hilum it is 5 centimeter away, and near the lower pole it is 7.5 centimeter away from the vertebral column. Okay, understood? কে কথা বলছে? কন্টিনিউয়াসলি কথা বলেই যাচ্ছে। এই সামনে এগিয়ে আয় তো, তোকে বলছি। তোকে সামনে এগিয়ে আয়, টুল নিয়ে সামনে এগিয়ে আয়। ওইখানে বসতে বলিনি, এখানে সামনে এগিয়ে আয়। So both kidneys, the long axis of the kidney is slightly oblique, being directed downward and laterally, so that their upper ends and poles are nearer to each other than the lower poles. Both kidneys move downward in vertical direction and for 2.5 centimeter during respiration. They move almost 2.5 centimeter. Transpyloric vein passes through the upper part of the hilum of right kidney and through the lower part of hilum of the left kidney, because right kidney is lower in position than the left kidney. Now shape and measurements. Shape is bean shaped, you can see. Measurements, length is about 11 centimeter here. This is 11 centimeter from upper to lower pole. Left kidney is slightly longer and narrower, and width is about 6 centimeter. This is the width, 6 centimeter. Thickness is 3 centimeter. That is anteroposteriorly it is 3 centimeter. And weight is about 150 gram in males and 135 gram in females. Weight is asked in your viva sometimes. Okay. So kidneys, each kidney presents these following features. Two poles, superior and inferior pole, that is upper and lower pole. Two surfaces, anterior and posterior surface. Two borders, medial and lateral border, and a hilum. So these are the presenting parts. If you are asked what are the presenting parts of a kidney, you have to tell all these. Okay. So now we will discuss individual parts. First, the poles. Superior or upper pole, it is thick and round, lies nearer to the median plane than the inferior pole. It is related to the suprarenal gland. Inferior or lower pole is thin, pointed, and lies 2.5 centimeter above the iliac crest. Okay, so these are the two poles. Next, we go to the surfaces. Anterior surface and posterior surface. How will you differentiate? Anterior surface is convex, faces anterolaterally. Posterior surface is flat and faces posteromedially. Okay, so direction is important to hold the kidneys in anatomical position. So hilum will be directed slightly forward to place the anterior surface anterolaterally and posterior surface posteromedially. However, in practice, it is difficult to recognize anterior and posterior surfaces, and this is, however, easily done by seeing the relationship of structure present in the hilum. Okay, relationship of structure in the hilum is vein, artery, and ureter. Ureter will be most posterior, and you place it like this that ureter is not kinked. Okay, understood? Next, we go to the borders. It has a medial border and one lateral border. Medial border is convex above and below near the poles and concave in the middle here. It slopes downward and laterally and presents a vertical fissure in its middle part called the hilum or hilus, which has anterior and posterior lips. Lateral border is convex. This is lateral border. Next is the hilum. Hilum, the medial border, central part of the medial border of the kidney presents a deep vertical slit called the hilum, and it transmits these following structures from anterior to posterior. VAU, renal vein, renal artery, and renal pelvis or pelvis of the ureter. Okay, these are the structures passing through the hilum from anterior to posterior. Here you can see vein, then artery, then ureter. Okay, here also this is a cross section through the kidney, vein, artery, and then ureter. Now the relations are important, asked in viva. Anterior surface of right kidney, on the right and left side the relations are different. Okay, so anterior surface of right kidney, here lies the right suprarenal gland, right lobe of the liver, second part of duodenum, hepatic or right colic flexor, and jejunum. liver or jejunum are separated from the kidney by peritoneum. Okay, that means these two areas are peritoneal area and rest of the surface is non-peritoneal. Next, anterior surface of left kidney. It is related to these structures: left suprarenal gland, spleen, stomach, pancreas and splenic vessels. Left colic flexor, jejunum. Stomach, spleen and jejunum are separated from the kidney by the peritoneum and rest is non-peritoneum. Okay, understood? See, these are the different areas. Here is right kidney. This is suprarenal area, hepatic area, duodenal area, colic area, and this is jejunal area. And for the left kidney, this is suprarenal area, gastric area, pancreatic area, jejunal area, colic area, and this is splenic area. Okay. To practice this diagram, the anterior relation of the kidney. Next, go to the posterior relation. On the posterior, on both sides, same structures are present. Posterior relations of two kidneys are the same, except that right kidney is related to one rib, while left kidney is related to two ribs. Because left kidney is higher, that's why two ribs are coming in contact. So four muscles are present, those which was present in the posterior abdominal wall: diaphragm, quadratus lumborum, psoas major, and transversus abdominis. These are the four muscles. Three nerves are present. All these are present in the posterior abdominal wall. Subcostal nerve, root value is T12. Iliohypogastric and ilioinguinal nerve, root value L1. The subcostal nerve is accompanied by the subcostal vessel. Okay. One or two ribs. The right kidney is related to the 12th rib, whereas the left kidney is related to the 11th and 12th rib. Okay. See, this is the posterior relation. Right kidney related to 12th rib and left kidney 11th and 12th rib. This is the attachment of diaphragm, median arcuate ligament, lateral arcuate ligament. Okay. This is psoas quadratus lumborum. Here is the psoas major and here is transversus abdominis muscles are related. These are the three nerves: subcostal nerve, iliohypogastric, ilioinguinal. Along with subcostal nerve, subcostal vessels are present. On this side also the same: psoas major, quadratus lumborum, transversus abdominis, subcostal nerve with the vessels, iliohypogastric and ilioinguinal nerves. These are the posterior relations of the kidney. Now, capsules. Capsules are important. From inside outward, kidney is surrounded by four capsules or coverings. First is the fibrous capsule or true capsule. Okay, this is kidney. This is a longitudinal section through the kidney. So this violet colored one is representing the kidney. Outside it, the black line is the fibrous capsule or true capsule formed by condensation of the parenchyma of the kidney. Outside it is the perirenal or perinephric fat. This yellow area with some dots, this is perinephric fat. Then there is renal fossa or false capsule. This green one is the renal fossa or fossa of Gerota or false capsule. Okay, reflection of this renal fossa is asked in your viva. Pararenal then or paranephric. This is perinephric fat outside the kidney, and outside the renal fossa will be the paranephric fat or pararenal fat. This is very important. It is lying only on the posterior surface. Location is important. Okay, and it separates the kidney from the posterior abdominal wall. Understood? And see here, this renal fossa, it is fuses with, it has two layers, anterior layer and posterior layer. These two layers are continuous downward and enters into the pelvis, and above these two layers fuses above the upper wall of the kidney. Okay, then it again separates and encloses the suprarenal gland in a separate compartment and extends upward to be attached with the diaphragm. Okay, understood? This is reflection, longitudinal reflection of the renal fossa. So fibrous capsule, it is a thin membrane. So we'll discuss individual layers now. So first is fibrous capsule or true capsule. It is a thin membrane which closely invades the kidney, formed by the condensation of fibrous connective tissue in the peripheral part of the organ. And the capsule passes through the hilum to line the renal sinus and becomes continuous with the walls of calyces where they are attached with the kidney. Next is perirenal or perinephric fat. It is a layer of adipose tissue surrounding the fibrous capsule of kidney. This fatty capsule is thickest at the borders of the kidney, is prolonged through the hilum into the renal sinus. And in chronic debilitating diseases, the depletion of perinephric fat can and depletion of perinephric fat occurs towards the lower pole of the kidney, and it fills the paravertebral gutter and forms a cushion for the kidney. Okay. Now renal fossa or false capsule, fossa of Gerota. It is the fibroareolar sheath which surrounds the kidney and perirenal fat. It consists of two layers, an ill-defined anterior layer, also known as fossa of Told, and a well-defined posterior layer, fossa of Zucker candle. So, what are the extensions? Superiorly, these two layers first enclose the suprarenal gland in a separate compartment and then fuse with each other and becomes continuous with the diaphragmatic fossa. Inferiorly, the two layers remain separate and enclose the ureter. Anterior layer is gradually lost in the extraperitoneal tissue of iliac fossa, while posterior layer blends with the fossa iliaca. Okay. Laterally, the two layers unite firmly and becomes continuous with the fossa transversalis, lateral reflection. And medially, the anterior layer passes in front of the kidney and the renal vessels, marches with the connective tissue surrounding the aorta and the inferior vena cava. And the posterior layer passes behind the kidney and it is attached to the fossa covering the quadratus lumborum and psoas major. Okay, so these are the reflections: anterior, posterior, medial, and lateral reflection. Okay, superior, inferior we have seen in the picture, and medial, lateral. See, this is superior and inferior reflection. Here is the medial and lateral reflection. Laterally, two layers are fused and then continues as the fossa transversalis, fused with the fossa transversalis. And medially, anterior layer passes in front of this aorta and IVC fuses with the layer of the opposite side. And posteriorly, it is fuses with the fossa covering quadratus lumborum and psoas major here. Okay, understood? So this is transverse, this medial and lateral reflection. And superiorly, it is attached with the diaphragmatic fossa. Inferiorly, this posterior layer is attached with the fossa iliaca. Anterior layer is lost in the pelvis. Next is paranephric fat or pararenal fat. It is a layer of fat lying outside the renal fossa, and it consists of considerable quantity of fat being more abundant posteriorly and towards the lower pole of the kidney. This is important position, more abundant posteriorly and towards the lower pole. It fills the paravertebral gutter and forms a cushion for the kidney. Now we go to the interior of the kidney. When the kidney is split longitudinally, it presents the kidney proper and the renal sinus. So this part is the kidney proper, and this tree-like branching pattern, this part is the renal sinus. Renal sinus is the area which contains the renal pelvis and the renal vessels, lymphatics, etc. Okay. So first we will discuss the kidney proper. The naked eye examination of kidney proper presents a outer cortex, inner medulla. This part, this thin area is the outer cortex, and these are the pyramids. Pyramids are included within the renal medulla. Cortex is located just below the renal capsule. Outer covering is the true capsule or fibrous capsule. So cortex is located just below the capsule and extends between the Renal pyramids as renal columns. See, in between the pyramids, this cortex is entering inside. That is known as renal columns of Bartini. Okay, columns of Bartini. And the cortex appears pale yellow with granular texture. The medulla is composed of 5 to 11 dark conical masses called the renal pyramids. Pyramids of Malpighi. So these are the renal pyramids. Apices of the renal pyramids form nipple-like projections that is known as the renal papilla, which invaginate the minor calyces. See, base is directed towards the cortex, apex is directed towards the calyces, okay, towards the minor calyx, forming the renal papilla. Next, renal sinus. So outer part is cortex, inner here is the medulla, and this area is known as renal sinus. What is renal sinus? It is a cavity of considerable size present within the kidney. It takes up a large part of the interior of the kidney and opens at the medial border of the kidney as the hilus. What is the contents of this renal sinus? This is important. Asked in your viva. Greater part of renal pelvis, major and minor calyces, renal vessels, lymphatics and nerves and fat. And the renal sinus is lined by the continuation of two capsule of the kidney. Okay. See here, this is the capsule. It is continuing to line the renal sinus. Numerous nipple-like elevations or renal papilla indent the wall of the sinus, okay, near the minor calyces. And the renal pelvis within the sinus is divided into 2 or 3 large branches called the major calyces, and which further divides to form 5 to 11 short branches called minor calyces. See here, these are 2 major calyces. They are dividing into minor calyces. Okay. Now arterial supply. Kidney arterial supply has been discussed in details in your lecture. Okay, so shortly we will discuss here. Kidneys arterial supply is very important. Comes as a long question. Okay, so kidneys are supplied by renal arteries. Usually there is one renal artery for each kidney and arise directly from the abdominal aorta. So these are the renal arteries. About 30% individuals accessory renal arteries are also found. Renal artery divides into anterior and posterior divisions. You can see here the division: anterior for the 4 segments and posterior is for the posterior segment of the kidney. So anterior division supplies the apical, upper, middle and lower segments, and posterior division supplies only the posterior segment of the kidney. And the branches supplying the segments are called the segmental arteries. This lower artery is the segmental artery. Then segmental arteries divides into interlobar arteries passing between the pyramids within the renal column. And then they are dividing into arcuate arteries. From the arcuate artery, these arteries are interlobular arteries. Okay, and from where the afferent arterioles are arising and forming the glomerular capillary plexus, from their efferent arteriole, then peritubular capillary plexus. Okay, so this is the division. Abdominal aorta giving renal arteries, segmental arteries, interlobar, then arcuate, then interlobular, 5 to 8 capillaries. Vascular segments has been discussed. These are the 5 segments: apical, upper, middle, lower and posterior. Okay, you have seen this. Venous drainage. The venous blood from the kidneys is drained by the renal veins, right and left renal veins. Lymphatic drainage. The lymphatics from the kidney drain into the para-aortic lymph nodes at the level of origin of the renal artery, L2 level, lymphatic drainage. Nerve supply, each kidney is supplied by the renal plexus of nerves which reach the kidney along the renal artery. And the renal plexus consists of both the sympathetic and parasympathetic fibers. Sympathetic fibers are derived from T10 to L1 spinal segments. Parasympathetic fibers are derived from both vagus nerves. Okay, so these are the nerve supply of the kidney. Next, we go to the clinical aspects. First one is floating kidney or hypermobility of the kidney. Kidney is kept in position by the perirenal fat and renal fossa. However, each kidney moves up and down with respiration. Movement is about 2.5 centimeter. You have learned, and if the amount of perinephric fat is reduced, mobility of kidney becomes excessive. That is known as floating kidney and may reduce the symptoms of renal colic caused by kinking of the ureter. A floating kidney can move up and down but not from side to side within the renal fossa. You have seen the reflection of the fossa, so it cannot move from side to side. Up and down movement can occur. Now, renal trauma. Kidneys are well protected by the lower ribs, lumbar muscles, and vertebral column. Still, a severe blunt injury of the abdomen may crush the kidney against the last 11th or 12th ribs and the vertebral column. And the penetrating injuries are usually caused by stab or gunshot wounds. Since about 25% of cardiac output passes through the kidneys, severe renal injury can lead to rapid blood loss. And blood from the ruptured kidney or pus in a perirenal abscess first descends the renal fossa, then trickles downward within the fossal compartment and may reach the pelvis. Okay, so this is the direction of pus flowing up to the pelvis from the kidneys. Next is transplantation of kidney, very frequently done nowadays. It is done in chronic renal failure in selected cases. Donor kidney is placed retroperitoneally in the iliac fossa. It is not placed in the posterior abdominal wall high up like normal position. It is placed retroperitoneally in the iliac fossa with hilum parallel to the external iliac vessels. Renal artery is anastomosed end to end to the internal iliac artery, and renal vein is anastomosed end to side to the external iliac vein. And the ureter is implanted into the urinary bladder. Ureterocystostomy is done. Microscopically, the kidneys are consist of nephrons. Okay, functional unit of lung is alveolus. For liver, it is lobule, and the functional unit of kidney is nephron, and smaller number of collecting tubules, and each kidney has about 18 lobes and 1 million nephrons. Okay, nephrons you have learned during your 12th, okay, so no need to discuss. Nephron can come as a long question, different description, different parts, Bowman's capsule, glomerulus, its different linings. In histology you have read also PCT, leukophile, DCT, all those will be asked. Collecting tubules, their lining, epithelium, what are their functions, like this. Okay. So all this has been discussed. So this is afferent arteriole. It is forming glomerular plexus. Then from there, efferent arteriole is arising, forming the peritubular plexus. Peritubular capillaries, they join to form the venules. Venules are draining into this vein. Okay, and this is around the glomerulus. This is Bowman's capsule, prospicity, leukophile, DCT, and here is the collecting duct. Okay, and see here this afferent arteriole, this glomerulus and the part of the DCT, they are together forming the juxtaglomerular apparatus. Okay, that also comes as a short note.
juxtaglomerular apparatus. The two types of nephrons are present. Cortical nephrons with short loop of Henle. This is one cortical nephron. And juxtamedullary nephrons with long loop of Henle, like this. Okay. Differences, glomerular, all this you have learned. And this is also important, histology of filtrates and membrane. It consists of three layers, okay? Endothelium of the glomerulus, single layer of capillary endothelium with fenestration. It prevents RBC passage and passage of WBC. This is the endothelium. Basement membrane, this one is the basement membrane between endothelium and visceral layer of glomerular capsule. Prevents passage of large protein molecules. And filtration slits in podocytes. See, these are the podocytes. In between these footpads of podocytes, there lies the filtration slits. Podocytes, specialized epithelium of visceral layer of the Bowman's capsule, foot-like extensions with filtration slits between the extensions. Restricts passage of medium-sized proteins. Okay. So the filtrate then diffuses across the Bowman space into the tubules of the nephron. In the tubules, some substances are added to the filtrate as part of the urine formation, and some substances are absorbed out of the filtrate and back into the blood. That's how urine formation occurs within the nephron. Okay. Okay, juxtaglomerular apparatus. The distal end of the renal tubule passes next to the glomerulus to form the juxtaglomerular apparatus. Juxta means next to glomerulus. Okay. So juxtaglomerular apparatus consists of cells located in and around the glomerulus and the glomerular capsule. So it consists of two types of cells mainly, juxtaglomerular cells and macular densa cells. Juxtaglomerular cells secretes the hormone renin, and macular densa cells, it is sensitive to the concentration of NaCl. Okay, this is lining the afferent arteriole, macular densa, and also there is Lassie cells. Lassie cells are mesangial cells lying in between the capillaries of the glomerulus. Okay, so these three types of cells are together forming the juxtaglomerular apparatus. Very important short note. Now these are the functions of kidney. Okay, this is asked in your viva if kidney is asked in viscera. Urine formation, excretion of waste products, regulation of electrolytes, regulation of acid-base balance, control of water balance, control of blood pressure, renal clearance, regulation of RBC production. Erythropoietin is secreted by the kidney, helps in regulation of RBC production, and synthesis of vitamin D to its active form. Some enzyme of the kidney is involved in activation of vitamin D, and secretion of prostaglandins. All these are done by the kidney. So functions of kidney can also come as a part of long question or asked in your viva. Okay, so understood. So how will you hold the kidney in anatomical position? You have to first see the hilum of the kidney. Okay, hilum will have three structures: renal vein, renal artery, and the pelvis of the ureter. Ureter you have to place posteriorly. That's how you differentiate anterior and posterior. Okay, and this the border containing the hilum, that you have to place medially. So medial lateral is confirmed, and you have to check whether the ureter is kinked or not. If it is kinked, it is a wrong side. Okay, you have to place it like this, that ureter is not kinked. That's how you differentiate upper pole and lower pole. So you have to place upper pole more medially, okay, than the lower pole, and the hilum of the kidney more anteriorly than the lateral border. So medial border will be more anteriorly placed than the lateral border. That's how you hold the kidney in anatomical position. Understood? Anterior, posterior, differentiated by ureter will be posterior. Upper and lower pole, ureter should not be kinked. Okay, and medial and lateral hilum will be placed medially. Okay, that's how you differentiate whether it is a right kidney and left kidney. Okay, and in a cart section you have to see the cortex and the medulla. Within the medulla you have to see the pyramids, and within the renal sinus, if it can be visible, major and minor calyces you have to see. Okay, and in between the pyramids, renal columns of Bartini can be seen. Okay, and outer covering is the capsule or fibrous capsule of the kidney. So all these you have to see. Okay,